My name is Jody Waldron. I'm an internal medicine doctor and palliative care physician at Harborview. I spend about half my time on the internal medicine service as an inpatient doctor, and then split my palliative care time between an outpatient clinic and inpatient consults. And like Daryl had said, I really appreciate the fact that you all are here. I appreciate the invitation to talk with you. Thank you to Dr. Shaw. Thank you for Daryl for letting us join you. And I just want you to know that as somebody who also is working as an internist, taking care of a pretty sick population of patients at Harborview, I appreciate that I suspect many of you are here hoping to make this part of your care a little bit easier. This how to talk with patients, introducing palliative care. I think we all struggle with this, and I hope I can make it just a little bit easier. Okay, so for my disclosures, I have 4 evidence-based slides. The rest are based on a study with an N of 1, which would be me. So no actual or potential conflicts related to this. So I wanted to start off with a little bit of a case. This is actually a real patient that I've been taking care of. She's 39. I first met her in the hospital when she was recovering from her bone marrow transplant for AML. And had pretty severe graft versus host disease, and came to take care of her over time, and developed recurrence of her symptoms, and actually found out that she had recurrence of her disease roughly 17 months after her initial transplant and was thought to be in remission. She kind of was seen in the oncology clinic and were considering the next steps of treatment. Felt like her odds of remission with treatment was going to be about 50%, and her median survival would be about a year. Okay, so this is the patient that we're considering. I just want to acknowledge how hard it is to maintain this balance of what you guys are dealing with on the daily. Maintaining patients' hope, maintaining your role as a cheerleader and supporting someone through their challenges, being as honest and upfront as you can, being protective of them through this situation, through this scenario. I did medical school training at a hospital affiliated with Memorial Sloan Kettering, and I did my fellowship in palliative care affiliated with Seattle Cancer Care Alliance. I appreciate the fact that as providers in this specialty, you come across patients that have very strong feelings about the care that they want, and that you want the very best for them. And I just want to acknowledge how hard maintaining that balance is. So what are some of the things that we worry about kind of when introducing palliative care? First word, palliative, okay? So I think that it frightens people. We kind of don't know really what it means in spite of its pretty benign etymology, basically meaning to kind of cover over, or basically to placate and take care of the symptoms. It worries people. If they have an association, it's commonly a bad one. Okay? I think also the general kind of feeling that, oh, if I'm referring this person to palliative care, this is the same as referring them to hospice. The palliative care is abandonment, okay, that we've stopped fighting, and now that we've kind of left the patient to this alternative, lesser form of treatment, and we're no longer at their side. We're worried that if we discuss this or talk about this transition, kind of acknowledge the devil in the room, the patients may lose hope and they may die sooner. And I have a particular interest in palliative care for our kind of international and underserved populations at Harborview, certain cultural associations with maintaining hope kind of as this life force that keeps people going, and kind of the kind of direct truth telling that maybe some of our patients want. Some of our patients may feel like that's toxic. Family is going to be angry with me. The patient's going to be angry with me. Okay, and kind of this very challenging weight of, did I do the absolute best that I could for this person? Did I give them the most opportunity for life, the most opportunity for time with their family? It takes a lot of weight on for yourself. So again, these are some of the things that are kind of swirling in this milieu that we're trying to sort out in this moment. So first things first, kind of what's in a name. As I mentioned, the word palliative There's a study in 2009 that kind of was focused on providers and kind of what do they think about this word, palliative versus supportive. And it was interviewing with mid-level providers as well as oncologists. And the moral of the story was that, it distressed providers. They felt worried about it. It made them perhaps less likely to make a referral because that word is so loaded. Okay, and as far as the patient studies go, there is a study that basically discussed, it introduced the service using the word supportive care, and they broke that down into what they described was a traditional introduction versus a patient-centered introduction, both for palliative and supportive care. The moral of the story was that patients identified the term supportive care. Yeah. Patients identified the more supportive care as something, maybe I will need. It's less threatening, perhaps. I can envision that I will need some support going through this. It left them with a more favorable impression. And then for the descriptions of the service that involved the term palliative care, people felt like it was more associated with end of life, or they just didn't know what it means. Okay, so I would say that there's some issues with our branding and how we can describe our services that might be more helpful. I thought one interesting aside was there was a table from this study that broke it down by ethnicity, by education, by type of cancer, by race, et cetera, and whether they would want one introduction over the other. And I would suggest that we make an app for this, and then we can just program all those things in, and it'll just tell us the right thing to say, and we'll never make a mistake. So how do I describe our team? So what do I take away from these studies talking about what matters most to patients, what matters most to providers? I do feel like it's important when I introduce myself that I say, hey, we are appropriate at any stage of serious illness. I do get consultations for my outpatient clinic where the provider is saying, hey, I've got this 35-year-old who really has a normal life expectancy, but they're dealing with their pain management, et cetera. And sometimes I can help out with that, but really our wheelhouse are patients dealing with serious illness. And I mention that to patients. Do I say this is life-limiting, or people that are dying from illness? No, but are you facing something serious? Yes, they can acknowledge that. I also make explicit that we are an extra layer of support for our patients. And again, that term support is very non-threatening. Most patients think, support is one of those things, the more the better. We are specialists, okay? I do encourage you to say, these are specialists in symptoms. Why would you not want, a specialist managing it? I think that if anything, our healthcare system has come to prioritize specialty treatment and subspecialty treatment and subspecialty treatment even more and more. Let's use some of that cachet and acknowledge that palliative care providers are specialists. Why not get the best? Okay. I also mentioned, when we talk about this kind of assessing patients' goals, getting to know what's most important to them, I think that goals of care is jargon that we use all the time, and we talk about it in the ICU, we talk about it in the primary care clinic, and it means something to us. But I don't think it means too much to patients. Kind of, what are your goals of care? They're like, what the heck are you talking about? But I do think that if you say, hey, our team is going to get to know you really well. We might even ask you questions that you would never believe a physician or a nurse practitioner would be asking you, just to get to know you so that we can better tailor our care to what's most important to you. Okay? Why would you not want that? Okay? I think that introducing the service and introducing the topic, it can be helpful when patients are not talking about their weighty situation that they're dealing with right now. So that basically involves, has anyone in your family gone through something serious like this before? Okay, they can talk about end-of-life care. They can talk about the fact that someone died in the hospital versus died at home. They can talk about their prior experiences with hospice. It's not about them. It's not as frightening, not as threatening, okay? What do you remember about the care that they got as they got sicker? Well, I remembered that, the people from hospice were great and they helped us out a lot. Or I remember that, it was really important for Dad to be at home, et cetera. But they can tell you, they can introduce the subject perhaps without you kind of talking about them specifically. Okay, so I'm pretty sure that Daryl's going to mention the Temel study in the same way that Dr. Shah mentioned the Temel study and that Annie Hirano mentioned the Temel study. But I, too, will have to mention the Temel study. And I will say that just remember, that you are offering a drug that improves mortality by almost 3 months, decreases depressive symptoms by 22%, improves quality of life, okay? Just keep that in the back of your mind so that you can use the evidence to explain things to your patient, okay? You came here to get the care based on the most current research, okay? You're explaining to them, like, these are all the things we're gonna do to optimize your care. Recent studies suggest that with patients with cancer, we are acknowledging that this too is part of our body of literature that we can cite and you can teach your patients about the evidence, okay? We found that when this team is involved, patients actually do a lot better. So, why would you not want that, right? I think that this is particularly important. So I work, again, at a safety net hospital in Seattle. I take care of a lot of patients that face discrimination on the daily for one reason or another. I think that a lot of them are very reasonably and rightfully concerned about healthcare rationing, okay? I have patients that tell me, you know what, you're just kicking me out of the hospital because I'm a Medicaid patient. You're just stopping my chemotherapy because I'm a Medicaid patient. Well, actually, I'm not. I'm giving you palliative care because it's the best, it's what all the evidence says is the best kind of care you can get, okay? So I think it's important to just, acknowledge that it's not a denial, but actually on top of. Okay? I think that normalization of the use of palliative care is also really important. And for, the palliative care team helps me with many of my patients, okay? It's not just you, it's not just now, but this is many of my patients, okay? This is a very usual, this is the standard of care. Okay, in my experience, it helps to have a team approach as patients face more complex challenges. I hear this a lot from patients, again, in the population that I serve. Certain kind of cultural groups will, I feel like there's a lot of, personally, I feel like there's a lot of unknowns with medicine and a lot of questions that we might not have a lot of answers to. And I feel like some of my patients appreciate that acknowledgement. I also feel like some of my other patients don't like a doctor who says, I don't know the answer. So I think that it's really important. Patients are coming to you for your experience. You are the expert in the room. You've gone through this before. You've seen it before. It can be reassuring to them that you are saying, hey, I've been through this before. You can trust my perspective. In my experience, this team can be helpful. Okay, yes, it's serious, but what do we do when things are serious? We get extra help, okay? It's not the end of the world serious, but it's time for us to get some extra help. Okay, so I want to go back to our case. And again, a 39-year-old woman with recurrence of her AML, now considering what ended up being GCLAM for treatment of her recurrence, okay? So in this case, I would suggest that there are a couple of inroads. And again, I would not say that based on, kind of a small amount of writing on a text that, necessarily this is, when one provider would introduce palliative care, but I do think that in this particular case, the patient benefited. So the fact that she had severe gut GVHD in her prior bone marrow transplant, and very heavy symptom burden offers us kind of a little bit of an inroad for further discussion, okay? I appreciate the fact that, as specialists, we focus on symptom-based care. It gives me an opportunity to develop a relationship with patients based on that value that I bring to the table, okay? So, again, as the oncology provider, you could say, we need you to feel as well as possible to give you the best shot. Our team, in this case, is not associated with any change or transition in care. We're associated with giving you the most benefit from your ongoing cancer-targeted treatment, okay? I can't have your pain and nausea getting in the way of your treatment, okay? I need these specialists to help. Let's be sure that you feel as good as possible so that you can do the things that you need to do, okay? Again, there's nothing threatening about the palliative and supportive care team if they're helping you kind of do what you need to do. This team really knows what they're doing when it comes to symptom management, et cetera. So I just would encourage you to utilize the symptom-based treatment. Again, as oncologists, I'm sure that you are quite familiar with symptomatic treatment of a lot of the cancers themselves and keeping people, minimizing the side effects from chemotherapy, but a lower threshold to introduce a team earlier for symptom management when down the line that team might need some more credibility with the team or with the patient. Okay, so back to our case. I mentioned that this patient came to their clinic appointment with her parents, okay? I think that it's really important to acknowledge that palliative care not only takes care of the patient, but also of the kind of family and supporting caregivers. And I advertise this fact, okay? So we recognize that this kind of affects the whole family. And that's an introduction for how this team can help. I want to be sure that everybody, not just the patient, gets their stress kind of addressed. In a couple, you might say, hey, I want you to meet this team so I can be sure that A, you're taken care of, but also that your spouse is taken care of, because this is a stressful thing for everybody. A lot of our patients feel much more comfortable talking about the needs of their loved ones and families than they do talking about their own needs. Okay, it's a lot easier for them to say, you know what, I'm fine, I'm gonna get through this, but I'm worried about my parents or I'm worried about my loved one. And you can acknowledge how important that is to them and use that as an entryway to help them and say, like, I recognize that's important to you, I'm gonna keep an eye on your loved one so that you don't worry about that as much, okay? Another important benefit to acknowledging the role of family and invoking the family, as you're getting to know them, it gives you the opportunity to say, okay, your partner is going to be your surrogate, your parents are going to be your surrogate, your friend is going to be your surrogate decision maker in case anything happened to you. Now that I know that, help me guide them, okay? So basically, playing the role of surrogate can be very stressful, particularly if you've not had a conversation about what these advanced directives or what these interests would be. So I often will have patients say, okay, if anything happened to you, who would you want to make medical decisions for you? I would want it to be my wife, and you say, okay, in order to make this process as easy as possible on your wife, let's talk about this a little bit beforehand because I don't want her making decisions in the dark. Okay? That way, the patient is not talking about it because it's going to happen next week. They're talking about it to protect their loved one, which is a much more feasible process. Okay? So I will oftentimes use this kind of question of identifying the surrogate and then protecting the surrogate by having some discussion about advanced directives. Okay? Obviously, it's really important to be checking in with your patients kind of through the course of this process, okay? So tell me what's going through your mind right now as we talk about this. I think it's a very easy thing to feel like a conversation is going one way and the patient is sitting quietly and they leave your office with a totally different impression of what happened. So it's really big nods. Emphatic nods. So it's really important. I mean, this is the standard ask, tell, ask, okay? You ask some questions at the beginning, you give folks some information, and then you're asking about what you've talked about so that you're sure that the loop is closed. So checking in, I mean, I think the last thing we want to have happen is to have your relationship kind of threatened by misunderstanding. So checking in with them after you've talked to people about this. Some people might be a bit anxious hearing about needing another specialist. Kind of what are your thoughts about kind of incorporating this team? If something doesn't sound or fit right, I need you to let me know, okay? I don't want you leaving here kind of with some questions that I didn't answer, okay? Many of my patients think a lot more on the inside than they put out on the outside. Can you let me know kind of what's going on for you right now? Okay, so I think that I will say that I benefit from working in a healthcare system that's very saturated with providers, and we do have access to palliative care specialists. I would say, and I would encourage you, for those of you who are practicing in kind of areas where their access to palliative care specifically is more challenged, please take my card. Please don't be shy. Let me know if you have just concerning or patients that you just kind of want to run things by. I work a lot with, with the teaching services in the hospital, teaching primary palliative care, and sometimes it's just helpful to kind of reframe things. So like I said, don't be shy, reach out if you have questions. For those of you who are working with palliative care providers, share your concerns about the provider or the patient. When you've introduced palliative care to your patient, if you have concerns that palliative care is going to come on too strong, or that they're going to they're going to go straight for that code status discussion the day they meet the patient, and this is going to go down in flames, just let the palliative care team know what your concerns are. Just be like, hey, in my experience with this patient, maintaining hope is very important. Maintaining positive language is very important. They're having a lot of difficulty with pain. These are the things that I want you to know before you start seeing this patient, so that, palliative care, it is part of our training to kind of get a patient's understanding before we start kind of offering our suggestions and information, but give us the insight that you guys have with the relationship that you've already built. Okay, and get on the same page. I mean, you guys have experience taking care of these patients, and say, this is what I think is coming down the road for this person. And the palliative care provider can kind of give you that, you guys can get on the same page and talk about what you're anticipating. Okay, so most of this has been about talking about palliative care, which I think is, as long as we kind of include the word supportive, can be a little less threatening, a little easier, a little less of a categorical change in treatment plan. How do I talk to patients about hospice specifically, and just acknowledging that hospice is included in the window of palliative care, under the umbrella of palliative care, but really represents, what I think of as, would I be surprised if this person passed away in the next 6 months? Okay, so that being hospice. I warn people to be very careful about cavalier introduction to hospice based on another provider's description of where the family is. Okay, I've walked into rooms and I've kind of talked, and said, hey, I hear you are interested in hospice. I'm here to help you with that. And the family kindly or not so kindly is just like, we never want to see that doctor again, because that's not what it's all about. And again, the moral of the story is assess understanding, assess where the patients are before you start saying anything, really. And so I always caution the folks that I work with, just get a sense. Again, this is another place where you can use that. Tell me what your experience is, your prior experience is with serious illness. They mention hospice, and then you can kind of use that as a little bit of an entryway. Okay, acknowledge the fact that most patients think hospice means days, because the studies suggest most hospice means days. We underutilize the service, and just know that that's what the word means for patients, and you can correct them and say, yeah, unfortunately it's a service we don't utilize enough, and frankly, I think that most people would benefit from longer time kind of with these benefits. I do talk about the benefits before people's minds shut off when I, drop the H-bomb of hospice, and they're not listening because it just doesn't apply to them. I talk about the benefits a little bit, okay? I talk about the fact that, the caregivers are providing a lot of the care at home or family, but it would mean a nurse coming 1 to 3 times a week. It would mean that you have a health aide coming a couple times a week to help with bathing. It would mean that you have a social worker who's just helping you put out the fires of kind of planning and making sure that that stuff is secure. You have a chaplain who's there to check in with you. You have people who are there to make sure you have all the equipment that you might need at home. That sounds pretty good. And I'm not saying, it's all smoke and mirrors and you can trick people into being on hospice, because that's not what palliative care is about either. But I do think that it's important that the patients know what the benefits are before they make a decision. I think in general, I think there was actually just an article on NPR about this kind of 1 in 5 patients that actually discharges from hospice and doesn't die on hospice. I think that the oncology trajectory is probably a little more, the oncology trajectory of a patient who qualifies for hospice is probably a little more linear maybe than a heart failure trajectory or a COPD trajectory that may have a little more fluctuation. But I do tell my patients, about 1 in 5 patients that I refer to hospice, actually it turns out that they do a lot better because they're getting more attention at home. They're getting people paying attention to their symptoms. And some of them actually get better, and after 3 to 6 months actually don't qualify for hospice anymore. I don't sell that as like guaranteed, but I do say, it happens about 1 out of 5 time, 20% of the time. So that can be important. I always describe it as a benefit that people have earned. Okay, this is a Medicare benefit. People have invested, they've worked hard. We want to be sure that you get all the benefits that you've earned kind of with your Medicare, with your insurance coverage. This is something that I want you to take advantage of, okay? Get your money's worth. Like these are, it is a valuable service, but just letting people know that it's not a way for us to save money. It's a way for them to kind of take advantage of what they've invested in. Okay, so going through this process, as you all do with some frequency, it's important to take a step every once in a while and say, what are my referral practices? Who are the people that I'm referring? Did I refer to that person too late? Did I refer to that person too early? Did that process go well? Did that go poorly? Kind of asking yourself about what are your habits? And this is just a part of general kind of self-reflection as a healthcare provider. How am I striving to get better? Okay, talk to your colleagues about language that works for them. Okay, I think that really the nuts and bolts of a palliative care fellowship is just an opportunity to steal language from your friends. So kind of take advantage of the collective brain and find out what has worked for your colleagues. And ask, it's easy to pick up the phone. Palliative care providers, I've never heard one be mean with a consult, but just say, hey, I've got this patient, like, what are your thoughts? Like, does this sound reasonable? What should I be nervous about, et cetera? Just to have some other perspective. Okay, as Annie had mentioned, there are some tips that are, pretty oncology specific and certainly very oncology friendly. The vitaltalk.org website, the Vital Tips app is free, very low investment, and it talks about basic communication tips, et cetera. The Vital Talk app costs a couple bucks and basically offers some videos of conversations so that you can kind of see how various care providers are introducing the idea of palliative care or kind of breaking bad news. Again, it talks about these communication tips very much as a skill that a provider can learn and perfect, and offers you some kind of goals yourself for how to improve your communication skills. Okay, so some of the key points. I think support should be a key part of your pitch when you're talking to patients. It's something that we all universally feel is appropriate for oncology patients in particular, and patients and providers, are not threatened by the word. Talking about others can be a good starting point, i.e., what kind of experience with serious illness has your family had? Tell me a little bit about that. Speaking from your experience, again, because you guys are, you're the experts in the room, people need kind of your sage advice, and they need to know that you are sage. It helps them with their anxiety and worry that, you're with them for the ride. So talk about your experience. Like, in my experience, this is what I've seen, okay? And it makes it not only about them, but also about you as an established provider. Teach your patients the evidence in the same way that you teach your fellows and your trainees and your colleagues the evidence, okay? Talk about the fact that the standard of care and the best care may include palliative care, and it may offer mortality benefits. Finding a thread that allows you to introduce palliative care, whether that's symptom management or support for the family, can give you a gateway to introducing palliative care early and allowing them to develop a relationship. So again, you can tailor the care to the patient as things go on. And just talk to the palliative care team if you have worries about a new consult you're giving them, if you have questions about the timing and appropriateness of a consult, and to make a warm handoff, because like I said, you guys invest a lot of time in the relationships you build with your patients, and the warm handoff helps us capitalize or use the capital you've invested. Okay, this VitalTalk app and website can offer some language that can be helpful. And if you guys have any questions, I think maybe we can take them as a part of the panel.